10 tips and tricks in meniscus repair. Lateral meniscus portals, usually the viewing portal is the anterolateral portal and your working portal is the anteromedial portal. What about the medial side? Your visualization portal is usually, as before, is the anterolateral portal, and the working portal is going to be anteromedial portal. But when you are using a repair, you need to switch the portals. Your viewing portal will be the anteromedial and your working portal will be your anterolateral portal. So zone specific cannulas are not truly zone specific. You can interchange and use when and where in special situations. Sliding knots are very useful. Inverted buried sutures can be used in horizontal cleavage tears, and in certain situations like the parrot beak tears, crown feather sutures are very useful. Pleasure to share our experience on inside out meniscus repairs. For young arthroscopic surgeons, the learning curve for meniscus is quite steep compared with other ligament surgeries. So hope our talk here and the tips and tricks will help you flatten your learning curve. So for any meniscus surgery, especially lateral meniscus, positioning and portals are the key. For any meniscus surgery, you need to see the meniscus properly to do anything with it. Even it includes a meniscectomy. So proper positioning for a lateral meniscus, the figure of 4 position, where your assistant is important in opening out the lateral side. Sometimes it might be needed to flex the knee for more than 90 degrees and lift it up with internal rotation of the tibia will help to visualize. And the position of your portals are also important. Too high a portal might lead to difficult visualization. And the same for the lateral meniscus portals, usually the viewing portal is the anterolateral portal and your working portal is the anteromedial portal. So when you're doing an inside out repair, usually for the posterior, you try to come out a little posterior. You need to protect your posterolateral structures. So there are various instruments, but the commonly used one is a spoon. A local cutlery spoon can be used to pass it deep to the gastroc, between the gastroc and biceps muscle, and protect the neurovascular structures. This is a commonly followed technique which will protect the neurovascular structures. But there are other ways to do it. Normally these cannulas used for inside out repair are called as zone specific cannulas. As you can see, there are various cannulas for each side, right and left, and the curvature of the cannulas varies from anterior being more curved, middle being less curved, and the least curved is the posterior cannulas. For the posterior part of the meniscus, you use the posterior cannulas and so on. But are they truly zone specific? Here I will show you some example where if you use an anterior cannula in the posterior part, your exit point, rather than being more posterior, you can get it more anterior. So your neurovascular structures are a little more safe, and you might not require to give a release incision posteriorly. A large incision can be avoided in this situation if you are able to switch the cannulas. This is a case example where I have used the anterior right cannula for the posterior part of the lateral meniscus. As you can see, it's easy and it's possible to pass using the anterior cannula. This is the exit point, but you make another incision anterior to the fibula head and you try to retrieve those threads which have come percutaneously using either probe or right angled instruments to retrieve these threads through the small hole. And you need to make sure the threads, both the ends of the same loop, are retrieved through the same plane, so that soft tissue entanglement is not there. And I prefer using the sliding knot. Here I am using the western knot. So when you use the sliding knot, you can pass the knots deeper than where your incision is there. So this helps to reduce your size of the incision and it can be placed away from the exit point. This the tip number 6 is on how to improve the visualization on the medial side. You must be aware of this MCL pie crusting, and it is very useful. It's just not useful for visualization, it is very useful to prevent a cartilage injury. During meniscus surgery, It's much more important to preserve the cartilage and not to damage the cartilage in trying to repair or excise the meniscus. So you must be bold enough and liberal enough to do a MCL pie casting when and where it is required. What about the medial side? Your visualization portal is usually, as before, is the anterolateral portal, and the working portal is going to be anteromedial portal. But when you are using a repair, when you use the cannulas, you might need to switch the portals. Your viewing portal will be the anteromedial, and your working portal will be your anterolateral portal. And when you exit medially, similar to what I showed on the lateral side, I nowadays usually avoid any medial incision. So it's in a case of ACL plus medial meniscus repair, through the hamstring graft harvest side, through the rent in the sartorius fascia, you can retrieve all the medial sutures, and you can use these sliding knots. And this is the routine way I've been doing it now for the past 2 years, and there's a publication on this recently as well. So it's an all arthroscopic medial meniscus, avoiding a medial incision. And what other special situations I would like to highlight is, like what Dr. DVR had told during introduction, is in complex situations. Previously, in situations where there was bucket handle tears with radial tear, we would consider it as complex and excise the meniscus. But with more and more experience, we learned that the small part of the radial tear can be excised, and the remaining part of the red zone tear can still be repaired. This goes to the same situation where there is a double bucket handle tear. The white zone can be excised and the red zone can be repaired. So you can still save the meniscus how much ever is possible. Whatever meniscus can be saved is actually useful. And another meniscus situation is the parameniscal cyst. We do come across these parameniscal cysts where it's usually associated with the horizontal cleavage tear. So after you decompress the cyst, it's very important to close the valve mechanism through which the cyst had formed. So closure of those walls of the tear in the meniscus is very important. And to another situation where there is a complex meniscus tear, where you might need to debride majority of the meniscus, you can do it step by step till you get stable meniscus. When there is a remnant of such horizontal cleavage, you can still repair this horizontal cleavage with mattress sutures. Such mattress sutures where horizontal mattress holds both the ends together. And to have a better approximation, rather than giving a kinking effect, you can place inverted sutures, as in this situation, where through the rent upper leaflet is passed with one needle suture and the lower leaflet is passed with another suture, so that this approximates these meniscus with inverted sutures. That's my tip number 2. This is totally buried sutures, so this approximates this horizontal cleavage. In this situation, an all inside air has been used and the posterior part is also repaired. And to the last situation where this is a flap tear or a parrot beak tear. This is a special situation where it's a white zone tear which extends into the red-white and goes on to the red zone. If you need to excise this particular one, we might lose about half of the meniscus. So in this situation, this is a special open-eyed needle where it was used to pass it through the center of the flap. 4 sutures were passed through the same passage, and each sutures were placed in the fashion like a crown feather of a peacock. I call it the crown feather technique, where 4 sutures are passed at different locations. So the thin flap just needs one passage of sutures, and the surrounding sutures are passed in various radial directions, and the final picture is like this. We have a series of cases with good outcomes, and this is also being sent for publications. So to summarize, so tip number 10 is the position and portals for lateral as well as medial. Using a spoon for the lateral meniscus is very important to protect the neurovascular structures. Zone specific cannulas are not truly zone specific. You can interchange and use when and where in special situations. Sliding knots are very useful. MCL pike resting is very important in the medial side. You can avoid a medial incision when you do medial meniscus repairs with an ACL reconstruction. Augmented excision with repair in various situations as we showed can be used. Parameniscal cyst closure of the valves are very important. Inverted buried sutures can be used in horizontal cleavage tears, and in certain situations like the parrot beak tears, crown feather sutures are very useful. And to various other surgical techniques, I will be showing it to you in the live session. Thank you very much.